I believe we can start. So I know that people are still coming and queuing for the devices. And even before we start, I will make a public announcement because the organizers asked me to. Please wear your badges. There's a huge amount of people without badges, and we are not sure who is the guest of our conference and who is not. The message is, yeah, that's the end of the message. So, welcome you all at our workshop on public health and harm reduction in Central Asia and the Caucasus. My name is Katarzyna Kowalczyk, and I'm the organizer of this workshop. And before even I will start to introducing our great panelists and my co-chair, Arkady, let me just briefly explain you the idea behind. So with my organization, the Global Public Health Network, a couple of years ago, we started to run projects in that region. And thanks to that, I met great people. Some of them are here. And I know that this part of the world hasn't got a presence at GFN it deserves. Also, there are a lot of misconceptions and myths about the situation there. So I thought, well, it's about time for us to discuss the region, to expose the region to you. But me, myself, I'm working in the field of public health and harm reduction. So mainly our workshop today will be dedicated to those issues. Of course, we will we'll touch upon the main focus of GFN. We will discuss smoking. But my goal and my intention is for you to learn a bit about the situation in the area of public health and harm reduction in those countries. Right, so I think we might start. And let me, one more thing. So the agenda is as follows. The agenda is as follows, so Arkady will help me to introduce our guests. Then each of our guests will have a short pitch, sort of introductory pitch to describe the key, or to deliver the key messages. Then we will initiate some discussion, but feel free to jump in. They are here for you, so feel free to ask questions, because I assume it will be interesting, and I assume you might have a lot of questions. So thank you.
Thank you, Kasia. I would say feel obliged to ask questions, because where there is data, there are questions, and questions arise, and they have to be answered in a proper way. Good morning to you all. Hope you slept well, and hope this first panel is going to be, I hope and I know that it will be an interesting one. So my name is Arkady Sharkov, but I'll be last. Let me first introduce our pleasant speakers this morning. Next to me, Dr. Alfia Semigulina, which is an honored physician of the Kyrgyz Republic, doctor of medicine, professor, rector of the Bishkek International Medical Institute, former deputy of the 6th Co of the Supreme Council of the Kyrgyz Republic. Next to her, Dr. Saida Umarova, doctor in medicine, associate professor, physician, has degree, first deputy minister of health and social protection of the Republic of Tajikistan. Next to her, Gintautas Kentra, Dr. Gintautas Kentra, a cardiologist, deputy chairman of the council, and member of the expert council of the Densalyuk EOL in Kazakhstan. Next to him, Mr. Amir Rashidov, a drug addiction clinician in the Republic Specialized Scientific and Practical Drug Treatment Medical Center in Uzbekistan. And last on the other side, Mr. Zurab Chabrashvili, former Minister of Labor, Health and Social Affairs, a Deputy Chairperson of the Parliamentary Committee of Healthcare and Social Affairs, Governor of the Kakheti region, and Mayor of Tbilisi. Ambassador Chabrashvili served as permanent representative of Georgia to Council of Europe and the UN office and the organization in Geneva. He has a rank of Ambassador of Extraordinary and Plenipotentiary of Georgia since 2007. It is a pleasure. As you see, it is an interdisciplinary team here, we can say, from all different areas, both from the medical, from the economic, and mainly from the policymaker field, people who develop their policies in their countries, and here to share good examples and also good ideas on how to improve public health. So let's start with Dr. Samigulina, the podium is yours on the topic of public health, and you have a short time to present your idea. Thank you.
Добрый день, уважаемые участники. Я хотела рассказать о
Good
ситуации в
morning,
Кыргызстане,
good afternoon, dear participants. I would like to tell you a few words about the situation in Kyrgyzstan. And the Kyrgyz Republic is a post-Soviet country. Space it became independent in 1991. And unfortunately, public health is still in its nascent stage. If we talk about the law and public health, then nowadays at this stage, the parliament, the Jogor-Kukinesh, has conducted discussions, and in the first reading, they submitted the law to be reviewed by the parliament members, but then it was returned back to be finalized. So it means that there are still many questions which were not addressed yet. And Kyrgyzstan is a very peculiar country among Central Asian countries, and those reforms which were embarked back in 1991, they are going on quite actively, and the country seems to be number one in terms of its reforms. But unfortunately, huge expenditures allocated for the health sector are not financed by the government. We have many projects which are still implemented at the expense of donors. So if it were not for the donor support, then financing for a key project is not sufficient in the country. So it turns out that Kyrgyzstan is one of the countries where the health services are paid from the pocket of our population or patients or their families. And as per capita, GDP is 6.5%. 6.5% of GDP is allocated to the health sector. It's one of the lowest indicators in Central Asia after Tajikistan. If we talk about the mortality rate from contagious diseases, and 75% of the population below 76 years old that they die because of non-contagious diseases. Why we have such a problem? First of all, because there are huge difficulties with outreach work. It's lagging behind. Prevention medicine is not developed because we don't have screenings, we don't have programs which would cover population without paying a fee. Even for prophylactics and prevention, population has to pay from their pocket. But given the fact that the living standards in our countries are low, then people focus less on prevention. So when NCDs become chronical, they have to pay more money, both for the country and for the patients, so that these diseases can be treated and to maintain at least some level of health, to be able to work, to be able to feed their families. So here I would like to draw your attention to the fact that out of all risk factors of development of NCDs, Kyrgyzstan ranks number 4 out of 180 countries in terms of salt consumption. So of course we have a big number of smoking people. On average it's 30% of adult population, and we also have a lot of people consuming alcohol. I think that these figures are not only figures pertaining to Kyrgyzstan, but to the neighboring countries as well. So these are the peculiarities of our country. Thank you.
Thank you, Dr. Samigulina. It's interesting to find so much similarities between what's happening in Kyrgyzstan and also in Bulgaria, especially in the field of medical practice and co-payment, out-of-pocket payment from patients, and the topic of prevention and prophylaxis as well. So, Dr. Umarova, your point of view.
Добрый день, уважаемые дамы и господа.
Good afternoon, dear ladies and gentlemen. I'm from Tajikistan. I wanted to tell a few words about the health sector status in our country. Our country is a mountainous country, and 90% of the territory is covered by mountains. So you can imagine that already this factor creates problems or barriers for the population to have access to health services. In 1993, after the Republic of Tajikistan became sovereign, it adopted the family medicine health sector concept. Now we have 3 levels of healthcare in the Republic, and the major focus is on the PHC. So the PHC facilities are more than 2,500 in the country. However, the material and technical base leaves much to be desired. And of course, in order to enhance PHC services, as the situation in Kyrgyzstan, we receive a lot of support from our development partners, such as the World Bank, the UNICEF, UNFPA, on screening of ulcer for women. And ADB is also supporting us to improve infrastructure of PHC facilities. However, we have a lot of problems, disproportions in operations of PHC level and hospital facilities. So the problem is mainly lack of qualified, skilled health workers, though we have 2 medical universities and several colleges. Nowadays, we have 20 doctors per 10,000 people. As for the mid-level health workers, 60 per 10,000 population. So we have a great migration outflow of health workers abroad, mainly to the Russian Federation, because the salary of doctors and the middle-level staff is very low. And health financing after the coronavirus infection increased a bit, but it still leaves much to be desired, so it has to be increased. So the country adopted the health code, which unifies more than 40 laws, and there are several national programs which are implemented to improve the situation, such as counteracting HIV infection, counteracting obesity, because obesity is increasing among young population, children and women. And in 2012, according to the demographic study, the obesity among women was 27%. Nowadays, it's already 38%. And in some regions of the country, child obesity increased from 3% to 7 and 12%. So this is an alarming sign and requires preventive work to be able to prevent such development. There is also increase in cardiovascular diseases, diabetes 2 disease. As for the oncology pathology, so it's a breast cancer, which ranks number 1, and among children is the malignant formations in the stomach and intestines. Notwithstanding the fact that the number of smoking people is not that high, only 10% of the population, maybe 1% of the men, and because of the tradition, many women conceal that they are smoking, and this could be businesswomen, even health workers, as we can note, though the statistic is not very accurate. Now we are assessing the non-contagious diseases, which ends in a couple of weeks, and we expect to have new data. So under the NCDs, the country adopted a program to fight NCDs in 2013, and it ends in 2023. So we want to take stock of the results, to have statistics to see the developments. And of course, we'll take all the measures to improve the situation. And I wanted to mention that among the population, we have many people who consume nasvaids, like chewing tobacco. So maybe half of the population is using this nasvai in the country, and this is a reason why the oncological diseases in intestine and stomach are increasing. And the scientists in Tajikistan prove the direct dependence of development of stomach ulcer and oncology is using this nasvai. So this is indicative of the need to fight this traditional type of tobacco consumption. And Of course, we assume that today the World Bank approves the new project on approval of the new project, the new strategy, and this work will be aimed at improving the preventive work, strengthening technical material base of PHC facilities so that we are able to identify pathologies on the early stage. So we don't have early screening as it was mentioned in Kyrgyzstan. Thank you.
Thank you, Dr. Umarova. From that point of view, actually, studies show that screening, it's interesting, this is for the Ministry of Economy and also Ministry of Finance, screenings increase the expenditure on healthcare for the first couple of years, but 10, 15 years into the game, it reduces the overall risk, which is beneficial for the healthcare and social and from the economic system. So policymakers tend to think to the future, but politicians typically tend to think short-wise in that term. That's why it's hard always to push such policies which are beneficial in the long term. This is from experience from my country. So, Dr. Kentra, the podium is yours.
Thank you very much. I'll continue as we started in Russian languages because it's common languages for our regions. И я давайте продолжу.
So I'll continue. Kazakhstan, as a post-Soviet republic, is rather well doing in terms of health financing. From this viewpoint, we are doing quite okay. And representing NGO Densovuk, which means health in the Kazakh language, this is the association of the concept of reducing harm from non-contagious diseases. We do not differentiate, we actually merge or bring together all negative impacts on health in one place. So our concept works in several areas, which includes the concept of harm reduction among injection drug consumers. We implement methadone therapy approach. And second, using nicotine containing products, we also use harm reduction concept. The third is the harm reduction concept when consuming foodstuff. I would say that this area is the most challenging one, but on the other hand, it's also easy because why it's challenging because it affects the whole society, but easy because it is understood by the government, by the Ministry of Health, because food concerns everyone. Then reproductive culture. Unfortunately, we have our own traditions in the region, and the problems of reproductive culture also have to play a big role. So it turns out that many families now cannot have children, and spreading infection and chronicalization of these diseases, which happen even before the first pregnancy and undesired pregnancy.
Казалось бы, меры очень простые, это просвещение, но национальные традиции
So, the national traditions in the countries of our region, the majority of population are devout and practice Islam, so we cannot follow the matrix of European countries, and we have to find out our own solutions, local solutions. So why we have chose this direction of this field out of all the areas which affect the health, because non-communicable diseases globally, we have the data on the mortality prevalence in Kazakhstan the same. 90% of this because of NCDs take place in Kazakhstan. In future, why we have chose this field? Because it is easier to work with the government, with the society, and the government. What is the concept of harm reduction? This is a universal arrangement and mechanism. It can be used in different sectors, in healthcare, in terms of safety and security at household level. And we know 8 to 10% of non-communicable diseases depend on the healthcare, and 50 to 70% depend on the individuals. And in order to decrease the burden of NCDs, we use this concept. What is the convenience of this mechanism? Nicotine-containing products, because it generates lots of negative perceptions. During the first presentation yesterday, it was told that this concern and problem is globally prevalent, and our government and the Ministry of Health is following closely the recommendations of the WHO. And we know this FCTC WHO Framework Convention, and we make reference to them when we promote the harm reduction concept of methadone therapy for methadone therapy among the drug users. On some side we authorize these concepts, and on the other side we prohibit them, and we try to unite all these approaches and concepts. At the Republican conference, we have made different proposals to include the harm reduction concept in the plan for development of the healthcare of Kazakhstan. And lately, the decree of the government was adopted, the healthcare development until 2025, which included the concept of harm reduction from NCDs on the whole. After we have included this, we have signed the memorandum with the Ministry of Healthcare, and to provide the training workshops for the doctors in the Republic of Kazakhstan on preventive medicine for the health promotion units. And for the last year, through online Zoom trainings, we have covered the majority of healthcare professionals in Kazakhstan, which included all of these areas, combating tobacco smoking, alcohol addiction, and nutrition, reproductive culture. And maybe I have missed something. These are the major areas which includes all our training workshops. If we focus on one aspect, there would have been major issues and concerns when on evidence-based, if we follow the evidence-based approach, all this reasoning about these approaches are strengthened, and we were able to communicate with the government and the Ministry of Health. There are some impediments. If we discontinue advocacy, then very soon the regress will occur. And this was approved on the methadone substitution therapy. Officially, these programs are ongoing. Because of the COVID, we stopped advocating this area, this field. The Minister of Health, of course, working in this direction, but they are not advocating anything. They're just implementers. And just recently, with the UN agency, Ministry of Interior, at the round table on promotion of this concept, further, the Minister of Interior was against this, irrespective of the legislative framework. We had the Ministry of Interior staff talking negatively about this approach and mechanism. It was scaled up in mass media. We can see these linkages. These authorities have the power. If if we lower our efforts, then we can lose time, and therefore we continue our efforts and advocate among the public associations and the new members of the newly elected members of the parliament. Sometimes some MPs stay in place and they are well aware of these issues. Sometimes we have newcomers. Sometimes the social issues generate lots of noise, and therefore we have to, at different platforms, we have to attract the new members of the parliament. The legislative framework should be supported and endorsed. These are the main areas which I wanted to share about these activities. And we have the NGOs, and we can criticize the performance of the Ministry of Healthcare and the government. Thank you very much.
Thank you, Dr. Kentra. It was very interesting, especially the part of tradition and religion in harm reduction. It's an interesting topic to develop later on if you agree upon. And also the middleman role, the role of the medical specialist in advocating the needs for such programs for prevention of usage of harmful products. So next, the podium is for Mr. Rashidov, please.
Здравствуйте, уважаемые участники 10-го глобального форума по
никотину. Good afternoon, good morning, dear participants of 10th Forum on Nicotine. We came together to discuss and address many issues related to public health, and I would like to share with you the current updates in the Republic of Uzbekistan. In many countries of Central Asia, the biggest share of mortality is to do with non-communicable diseases. From 70 to 83% of all deaths are related to this phenomenon, non-communicable diseases. And as you know, one of the leading causes of NCDs is the use of tobacco. In the Republic of Uzbekistan, we have our own peculiarities. We are very close to Republic of Tajikistan. We have this chewing tobacco snuff, nasvai. According to the latest researches and evidences implemented with the support of the World Bank and WHO steps, there is the trend of reduced small use of tobacco. However, the local academic evidences or researches show that for the last 10 years, there is a steady increase of use of tobacco. The scientists are drawing attention to this, why these figures are so different, where is the truth. And along with this, the share of population leading the less healthy lifestyle, the increased consumption of salt, a low mobility life, using the products cooked on the animal fat, and obesity, and also the share of people with high blood pressure and leukemia. And we understand the importance of combating of all these issues and concerns, and we are doing a lot on the part of the government and Ministry of Health. We are doing a lot, and we adopt different decrees and edicts of the president, and literally we have the law recently, the law on restriction and the dissemination or distribution of tobacco and alcohol products. In 1 month's time, this law will come into effect. And in addition, we have the program on combating tobacco smoking.
использования табака и алкогольной продукции.
and the using of tobacco and alcohol products. And we are quite confident that it requires joint efforts, and I'm very much happy we have represented from different ministries and agencies which are willing to unite their efforts to combat this problem and this concern, which is of global prevalence. Thank you very much for your attention.
Thank you, Mr. Rashidov, especially the interdisciplinary approach you marked at the end, especially when it comes to, if we're speaking about raising a healthy population, we speak about Ministry of Education, Ministry of Social Affairs, Ministry of Healthcare, combined efforts of the whole country and the whole power of the state. Next, Mr. Chabarashvili. Mr. Chabarashvili, as a former Minister of Labor, Health and Social Affairs, which is the heaviest burden for every government, those are the unlikely ministries. No one wants, it's very heavy burden for everyone who takes this job because it's very, how should I say, ungrateful. But give your perspective, especially in the field of public health.
Thank you, Arkady. Colleagues already touched some of the important issues, I think, and I'll dwell on some of them in my short introduction. The first is reliability of data and data collection in general. Some of the percentages being named already concerning prevalence of tobacco use in our countries presented here. In Georgia, it's around 30, but it's very difficult to correctly name now the exact number of prevalence due to the lack of the reliable data. We conducted steps in 2010, then 2016. Next had to be in 2022, but is missing still, and that's why there is a discrepancy between the various surveys showing the prevalence of tobacco use in Georgia. So my first message would be that to have reliable, comparable data, because even if you have the data from various surveys, sometimes the methodology differs and comparison is absolutely necessary. Second, what I would say is that how the policies are drafted and implemented in countries in general, and in particular in Georgia. The one way is what the advanced countries in harm reduction do, like UK, New Zealand, and others, that they rely on science. And science means they collect data, they analyze, and they see what is the best way to address the issues in a particular field. But scientific method includes discussion as well, meaning that the open discussion, not only within scientists, but within society, is important for first understanding the problem, understanding the issue. The second, to find the best solution for society, and importantly, to overcome the certain stereotypes existing in our society. When we are talking about the stereotypes, it's already mentioned about Kazakhstan, the methadone program, which exists in Georgia already more than 15 years. And I remember what kind of barriers been there to implement the program. The barriers were not only organizational or financial. Mainly it was the stereotypes in society. It was not easy to overcome. The same what I observe now concerning the use, the harm reduction understanding in tobacco consumption control is almost the same as we observed concerning the harm reduction in drug abuse. So that's very important, that data and then discussion. What happens in our countries? Okay, this forum is the very good forum to see what are of course, some of the scientific data are still coming. This is still the new field, the harm reduction in tobacco, but there are already success stories in these fields. I already named some of the advanced countries. And maybe sometimes there is a dilemma. What do you prefer to follow? You follow those who are in the front, or just to wait before this understanding seeds into every mind of the international bureaucracy? I will not name the specific organizations. And for politicians, safer is to wait for the international bureaucracy, because if the prime minister asks the health minister that why you do this, it's always easier to point at the international bureaucracy rather than to name the few countries who are riskier in applying the scientific data and method in drafting their policies in their countries. So we have to understand the motivation of politicians, why they choose this kind of safer for their own political career path rather than safer path for the public health and the society. What I want also to say about the few words about resources, and the primary care was named here by several colleagues as an important one. When we are talking about the harm reduction, of course, the first advice what the doctor has to give a patient is to quit smoking, of course, right? But then this is just, one is to say they quit smoking, another is to help actually them how to do that. And that's why it's important to have a well-organized, well-coordinated system in the healthcare where anybody who wants to quit smoking can apply to. And it was not easy. As I've said, in Georgia we have more than 15 years the methadone program, and it was not easy to set up the system. So in harm reduction in tobacco, the primary care doctors are very important to have the first to overcome certain stereotypes. The second is to actually help the patients to get results. So question of resources is very important. But still, we had a discussion on Tuesday. On these issues concerning Ukraine, Georgia, and Kazakhstan, and Dimitri, who is in audience here, asked me that if you would be a minister now, what you would do. And I continue saying that public debate, public discussion, providing data, and overcoming stereotypes, that's the key. Thank you.
Thank you, Zurab. And if Cassie would allow me just to give a short example from Bulgaria, and then I'm returning the word to you, Kasia. Thank you very much. From what I heard until now, there are actually a lot of those problems that you occur are still occurring in Bulgaria, although Bulgaria is part of the European Union since 2007. Healthcare everywhere is a troublesome area, especially when it comes to different interests. For instance, I can give a short example in Bulgaria, because we have a national health insurance fund, which is the main payer for services. 50% of the budget of the national health insurance fund goes for hospital care, 50, and only 22 to 23 goes to primary and secondary care. When we speak about medicines, around 33-34% go for there. So they're interested in these fields which are pushing against prevention and prophylaxis. Thankfully, for the past year, we adopted the National Cancer Plan, which is part of the European one, which is we have to do screening programs for the next 7 years in order to see what's the actual situation with cancer, because the main problem is Bulgaria that cancer is caught at a very late stage when it's very expensive to treat it, and the outcomes are very, how should I say, sad at the end. And another topic which is interesting, it might be interesting to you, with the new, as an advisor to the minister, with the new government that now was voted, there will be an accent on excise taxes as a method from which how should I say, policies could be made, especially in the field of harm reduction, or people can be pushed towards less harmful ways of using such substances. So it's a topic that it's also from the economic and also from the social sphere to be, how should I say, viewed upon with interest. So thank you, and Kasia, I'm returning the word to you.
I wouldn't say it's only Bulgaria. We all represent Eastern Europe, Central Asia countries. I'm myself Polish, which means that we all unfortunately have the unpleasant experience of Soviet times, and this is heavily still observed in the way our public system works, or actually not works. So, and thank you so much. And I have so much questions, so many questions, but before we'll jump into this, just to summarize what you have said, I would like to show some data summarizing the key public health and harm reduction problems. I'm just looking at Kamil to help me to bring on the presentation. It just showed that so first of all, this is what I wanted to start with, so that you know where are we from. So we should have started with this. Hope is accurate. You can find our guest here. But following up, so basically, so what I did is I collected the key public health indicators, and as you could see, we do not differ that much, especially one of which I found particularly interesting is healthy life expectancy. And let me just jump into this slide. It shows that well, the region itself maybe has higher life expectancy than an average, but still much is to be done and much is to be improved. And then because in almost all the presentation, there was this issue of non-communicable diseases. This is not only typical for this region. I think in general, this is the highest problem in public health. That would be actually my first question, because even though we share a similar history, there are some differences, and some of you mentioned diet, and I'm referring to diet because diet in your countries is quite specific and is related to also the history of your countries. This is what I've learned. Yeah, as a nomad countries, you were sort of forced by the Soviets to sit down, and some of the problems are linked with this and also with the past. Could you please elaborate more on this, because I found it absolutely interesting.
Кася, спасибо. Ну, у нас действительно объединяет.
Thank you. Katya. In fact, we have common history, that's true. And if we take some data, international data, average European indicators, if you take a diet or nutritional habits are different from European and American, these habits. And therefore, different diseases related to these disorders also can be seen. But take this as a base and extrapolate a certain region will be wrong thing to do. What we have happened to us a couple of years ago, we have public debate about soft drinks containing sugar, that this is very bad, and body mass index is growing, and our organization decided to go into detail, and we did our research, small research, in the biggest city in Almaty, in our polyclinic, and we covered a certain number of population, and we found out that use this soft drink containing sugar. Only young people use those soft drinks containing sugar. As people grow older, they use them less and less. What traditional people use? People traditionally in Kazakhstan have tea with milk, similar to English people. All age group, regardless of their age group. Every Kazakh citizen, in average, use 2 cups of tea with milk, put in 2 spoons of sugar. All age groups. And if we look at the data of other countries, where those other countries that don't have this tradition drink tea with sugar, many countries people drink water. We don't have another tradition. Usually with this tea we have something baked cake or something containing sugar and get additional calories and some light sugars. And if we look in details, what are the habits different regions, and besides that, according to WHO, we have 17 grams of salt consumption. So you can imagine, so this exceeds in many times, and all cardiovascular diseases and blood pressure is a result of this high usage of salt, because all our traditional dishes, they contain a lot of salt. If we start prohibit the salt, we know it doesn't work. We know, like with alcohol, if we ban tobacco, there will be some clandestine production of tobacco. Those bans don't work. If we start banning eating traditional food, we will be #1 enemy. We will cause resistance. And this harm reduction concept is not prohibited. It provides explanation and gives the right direction for people to follow. This is first. And family upbringing is very important to start with children, where you build this immune system against bad habits. And if child see that need to do certain things in school, explain this is a very bad thing, they will look and see how grandmothers and parents eating some fat food. And another aspect, if we do this, explain this to parents. So we need to continue to work. And we said yesterday
that it is a very easy way for the government to prohibit. You just adopt the law and prohibit, and means it's done. But what happens in the actual situation? The prohibitions, we know they don't work because it is dependence. Physical, psychological, and dependence is a medical issue. Just to prohibit dependence, it would be easy to treat all drug addicts, all tobacco addicts, but unfortunately, it's not realistic, it's impossible. So therefore, the harm reduction concept proposes that it should be done step by step, and it's working. And we were able to convince people with the methadone therapy, and the nicotine reducing program also works. Unfortunately, we still have to do a lot of work because of misunderstanding and because our government is looking for easy ways to prohibit. For example, in Kazakhstan, they prohibited selling alcohol and nicotine products for people aged under 21. But the average age when they start smoking and drinking, it's 17 and a half years old. Then how do they get it? So it means that the laws do not work and they won't work. Thank you. As for the meals, Tajikistan is such a country that in all regions, people have their own traditions, their own customs related to food. For example, in Gorny Badakhshan autonomous region, there are too many problems, unfortunately. Probably people have healthy foods there, and they don't consume a lot of fried and fatty food. But if we talk about the northern part of the country, which is Sagdiska Oblast, people like to eat a lot there, and mainly the way they cook their food is frying with like animal fats. And we can observe that the level of obesity among children and women is higher there. And the studies which were conducted in 2016 in the country, they indicated the problem which exists in the region, and that people consume a lot of salt. And this actually results in development of non-contagious diseases and heart-related pathology and diabetes. And the children consume a lot of drinks containing sugar. And the tea, by all means, should be very sweet, and it should be accompanied by other sweet cookies. So like cakes and bakery is available all the time on the table in the family. So we have to work with mothers, with families regarding increasing the awareness about the future of their younger generations. And I wanted to emphasize one good decision made by our government prohibiting marriages among close relatives. When they were not prohibited, we had many children with inborn defects, deficiencies. So when the government resolution was passed, it means that we can prevent these situations, and we have to start thinking about enhancing the health of genes. So when women start thinking what kind of diseases had her relatives, such as grandmothers, grandfathers, and parents, they'll start educating their children properly. So knowing which diseases can be inherited, they will work on preventing the diseases. So if mother and father knows, they will inform the child that there is a risk of developing such a pathology because they have some similar diseases among relatives. And the southern regions of Tajikistan are very different as compared to the northern part of the country. Of course, women also have obesity, but children are born with hypertrophy because there is a high level of anemia among pregnant women. This is an issue which is often discussed. And we do our best so that the pregnant women can have enough food, proper food, not to affect the development of the fetus. And our donors also work on hypertrophy among children. And every 5 years, we conduct a medical demographic study to study the deficiency of microelements in the food for children of early age. So here we have to enhance the culture and focus on the national specificities. Thank you. So if you allow me, I'll just say a few words. If we talk about the Central Asian countries, we have to mention that the key issue here is imbalanced food. So there are huge gaps, and we know that we like meat very much, especially fatty meat. So not a single normat can exist such food, and this is already defined genetically. At the same time, our countries are enjoying huge volumes of different fruit and vegetables, but unfortunately the majority of population do not eat them, and our pregnant women maybe 70–80% of them, as our colleague from Tajikistan mentioned, have anemia. In addition to that, they have chronic pyelonephritis, so it's a double diagnosis which affects the child which is properly born, but the fetus is not mature in this case. And the culture of meals is aggravated by inactive style of life. So in addition to imbalanced food, people are not active. So mainly they're active when they work in the office or do some work, but they do not work in the city, they don't visit gyms. Maybe it became a trend among younger generation who are, so to say, more successful, but the younger people of middle age who have no access to sports clubs or gyms, they are not doing any exercises. And we do not have small facilities with proper equipment in the parks, for example, where people can do some exercising. So this comprehensive or the lack of comprehensive work results into the fact that the level of obesity, the number of people with obesity is increasing in the country. And in addition, I also mentioned in my statement that non-contagious diseases mean a very long chronic process, and people got accustomed to it. They stopped noticing that something is wrong, and they don't have, so to say, a warning sign which indicates that they have to start prophylactics. So, for example, population doesn't measure blood pressure. They don't have a blood test for sugar. So they do not have those tests which we want them to have more often. And of course, we want people to be more active in this area. And as for public health sector, they approve and introduce a lot of programs, but financing is not sufficient for this program, and therefore all activity is to be the responsibility of the population per se. So all these activities are to be paid by the population from the pocket. So it's a vicious circle, and of course we could break it, and the concept of harm reduction is very essential in this area, because if we, in terms of prophylactics, indicate the alternative ways how to reduce the harm, how to switch to less harmful attitudes, this culture can be developed further in the years to come, and people become more responsible for their health.
So I'm curious to hear, is the concept of harm reduction well understood in your countries or at work? Do you practice this? Do you work with it?
So the harm reduction concept is at the initial stage of being introduced in our countries. If we talk about Kyrgyzstan, we started talking about it actively from October 2021. We had a roundtable, a big meeting, and the resolution was adopted at this roundtable with participation of parliament members and Ministry of Education, Ministry of Health, our academic circles, and the civil society. So this meeting adopted the resolution with a number of instructions for the government. At this stage, the harm reduction concept is introduced at the initial stage. So I would say it is step-by-step introduction. For example, in our Bishkek Medical International Institute, which educates future doctors, we focus on non-contagious diseases. And the harm reduction concept of NCD is the topic of studies of our institute. And professors and teachers and students focus on this particular topic. Last year, we conducted 5 surveys disseminating questionnaires among students of 5 universities, not only medical students, and we asked them about the risk factors of NCDs. So this work is slowly progressing, but I would say that we don't feel any large-scale support from the Ministry of Health in this area in our country. Tajikistan was much later working on the harm reduction concept. The methadone replacement program, as in all former Soviet Union countries, was launched much later. But at the same time, we also face some barriers in implementing it, but now it's successfully being implemented in the Republic of Tajikistan. As for the UN WHO Framework Convention, it was signed, and in 2018, the country adopted the law on restricting the sales of tobacco products. Thus, the country demonstrates that they can work using the harm reduction concept. As of now, the working group of the Ministry of Health developed the national program to fight oncological diseases till 2030. And under this national program, we included one of the global objectives to develop a harm reduction concept, which is to be approved at the level of the government. And in fact, this national program and the concept will be comprehensive, covering all areas such as fighting obesity, alcohol and tobacco, and environmental safety. So I think if we adopt such documents in the Republic of Tajikistan, then the harm reduction concept can be implemented in the country successfully. As for Kazakhstan, we started this work earlier than our neighbors, therefore we have some experience, we have some developments, but at the same time we do not rely only on the government in this area, because the government are officials. Officials are the same people who come as elected. They are promoted to different positions, but they have similar knowledge as just common citizens. So therefore, we are trying to work in several areas. By all means, the legal framework is very important. It's the work you do with the parliament. Then the PHC level is mandatory work, because the first thing is a patient comes to see his doctor. So these recommendations are not prohibitive, but related to reducing harm. That's most important. And another very important area which requires a lot of course, because we have very targeted interventions there, is working with the whole society. For this purpose, we use social networks, internet. We publish in newspapers newspapers, we participate in TV debates, we work through journalists of the society, and this work is important, including bloggers who are important. So this work should continue.
So when you have the opponents to your concept related to methadone, to nicotine program, the opponents are ready to prohibit everything, to ban everything, especially when it comes to protection of children. Yesterday, it was told that children, adolescents start using something harmful. We forget about the category who is already ill with some chronic diseases or the habits of the adult population. This is about awareness and human rights. We have, from the legal perspective, we have to protect the entire society, and we have to raise the awareness of the public. This is our top priority on our agenda, and it should not go only in one direction. This is a multidimensional activity. We have to work in many areas at once, and very important to engage with the society, with the public, and these debates on the harm on one-time vapes and some flavored vapes. We have different debates, but there is a lot of negative narrative, but we provide the line of reasoning, the evidence-based opinion. This is not about emotions. My kid is smoking and I want to prohibit. This is not about emotions. This is about evidences, and then it generates the positive outcome. Very briefly about the situation in Uzbekistan, the harm reduction program in Uzbekistan is about to be considered. As for the substitution therapy, opioid substitution therapy, we had the pilot implementation. It was stopped and it is no longer in place in Uzbekistan. There are some areas of fields for example, a syringe exchange and distribution of condoms, but we are at the phase of reforms and we use different concepts and programs, and from this perspective, we hope there will be the harm reduction program also adopted in the country.
Harm reduction in a society is linked, in my view, with the risk perception in societies. How we perceive risks associated with our life, health, etc., etc. So this is the we have to start with, and therefore, for me, it's always important to set the healthcare system in a way which motivates the public, and I concur here with our colleague from Kazakhstan that we have to take into account not only national bureaucracies and the politicians and decision makers, but wide public. The important thing is that the healthcare system motivates them to understand risks and to practice prevention measures in general. And that's why what Arkady mentioned about Bulgaria, the low utilization of the primary care in all our countries. It's a sign that there is a different kind of risk perception in our societies. There are, of course, the countries with successful single-payer systems where the prevention works. But in the countries with the Soviet past, international bureaucracy pushes for the single-payer healthcare systems, and without having a risk understanding in our societies, this leads to the low utilization of the prevention measures. And there is no understanding of risks, and there is no understanding of harm reduction. That's why maybe I started answering from too far about the healthcare systems, but how healthcare system motivates us and leads us to prevention, that's also important aspect whether that healthcare system includes harm reduction measures in various aspects or not. That's very important to take into account. And of course, it's correlated, the perception of risk correlated also with poverty and GDP per capita. The higher GDP per capita, the more society is inclined to tackle with risks. The lower the GDP per capita, people abandon risks. They think that they will not get disease, they will not get into the hospital, etc., etc. And that's why we have to also talking about in the harm reduction in tobacco. If we take countries where the harm reduction policies are well adopted, but take the lowest decile or quintile of the society in terms of the GDP per capita and compare it with the countries with the entirely same GDP per capita, we see that tobacco use prevalence increases in the lower income deciles on quintiles. So the perception of risks, which leads to harm reduction, also is very much, I think, correlated with income, and that's why it's important that more advanced our countries become in terms of economic development, more this sort of thinking will come into our mind and in our societies.
Thank you. I'm just looking at the watch, and I would assume that there are questions from the audience, so if I could ask for a mic. It's coming.
Добрый день, меня зовут Надежда Бедричук, я представляю организацию «Здоровые инициативы».
My name is Nadezhda Badrichuk. I work for Healthy Initiative. We operate in Ukraine and post-Soviet countries. I cannot say about Kyrgyzstan, Uzbekistan, and Tajikistan, but we have conducted researches, representative researches in Ukraine and Georgia. And we have done this 2 years ago. We could see that there are no changes in terms of perception of the harmfulness of nicotine and tobacco smoking. And many smokers and the major part of population believe that the most harmful agent in smoking is nicotine, and there are no changes, in particular in Georgia and Ukraine. And among the smokers, they have misconception that electronic cigarettes they don't contain nicotine. They're even more harmful than common traditional cigarettes. I have a question to our experts. If we have the conservative scenario and this attitude, how many years your countries will need to reduce the tobacco smoking by 80%?
Long time. But the longer the longer answer would be the following. What we see now is that the consumption of the combustible tobacco goes down in developed countries, in advanced societies, and the use of alternatives go up. This is part of the harm reduction policies. Of course, our societies will mimic the trend also. In 5 years, 10 years, the same will happen in our society, because through social media and the internet, people get information who are interested in. And then only after 20 years, our society may start thinking, aha, if that's happening, now we have to think about how to deal with the alternatives. While data already is there, and the successful policies are already there to take it into account. But this approach, what I mentioned, Nadia, that the governments usually prefer to follow what the majority of countries does, not the outliers. And UK and New Zealand or US and others, they are outliers for the moment. But this will be the trend in a decade. This is the next decade, right? And then we will start catching up, while there is a moment to catch up right now.
Ну, по срокам могу сказать, что мы не знаем.
In terms of the time frames, it is impossible to predict. But there are two scenarios. If we don't do anything, we will be left with the same figures and numbers. If we prohibition don't work much, they will generate very minimum outcomes. Only the harm reduction will generate the maximum effect and outcomes. We have to start with the healthy ones, not with the sick ones. If we continue these efforts and the more population is aware, is outreached, because this population includes the members of the parliament, and this is not 1 year of work. And the information which is accumulated in the minds of people, and it will create the gradual transition or a very sharp kind of leapfrogging effect. We can compare with WHO, which denies the concept of harm reduction, making reference to the Framework Convention. Will they change their policy in the future, and when will happen? Will this happen? Sooner or later it will happen. Maybe some other scholars will come with some evidences. We don't know about these time frames. If this happens to the WHO, then it would be much easier for us to use this data, and even the government officials will be more open-minded and more perceptive. And all of these are interrelated and interlinked, and we cannot be separated from the rest of the world, unfortunately or fortunately. And of course, they will have to look into the issues which are of good interest to the Minister of Health only, but the issues of interest to the public, they don't pay attention. Of course, we have to accelerate our efforts in terms of awareness raising.
Non-governmental organization from Georgia, Sharina. So my question is regarding preventive medicine, because all the speakers mentioned the importance of preventive medicine and considering the high rates of non-communicable diseases in all our countries, including my country. I have a question. So how can the system stimulate people to address medical institutions for preventive reasons, prophylactic reasons? And I do not mean here only existence of state-financed screening programs, because as we witness in my country, there are many state-financed screening programs, but just existence of these programs is not helping. So that's my question.
Thank you, Shorena. Though I touched the issue of the healthcare system, this question also gives me an opportunity to dwell a little bit on that. We had a system in Georgia till 2013 when healthcare system was organized through the private insurance companies. So, and we saw in those years before 13, we saw the increase in utilization of the primary care and the prevention. While when we went back to the single payer in 2013, the public money on healthcare increased and out-of-pocket payments being reduced, but almost 95% of that money went to hospitals, not to primary care, not to prevention, but hospitals. That's why when I've said that single payer, it just sucks the money public provides. The more you give them, more the system will use it. I mean, hospital side. But what we talk here and what is your question is about how to motivate public. And public is motivated when the financing of healthcare is based on addressing risks, meaning on insurance. As simple as that.
Yeah. May I add, Zurab said it perfectly, especially in the field. Of course, the main idea of the private health insurance is not to pay you for expenses at hospital care. The main idea is for you to remain healthier more years in order for them to have lower expenses. So this is one. Another thing for the stimuli, I believe in Germany there is, with all their Krankenkasses, there is this type of stimuli, which was if your GP tells you what you have to achieve until the end of the year as outcomes, in order to lower your blood pressure, stop eating unhealthy foods, walk more, etc., etc. If you achieve these outcomes, and there are clear measurements for them, like, for instance, cholesterol levels, and also hypertension levels, then part of your insurance input is taken out. So this is another type of stimuli, and more or less the best way I think to follow if there is a single pair, and if there is to follow through if someone goes to preventive care, is through voucher schemes. Voucher schemes, not giving money by hand, not giving stimuli only to the doctor, but giving through vouchers for you, for patients to go visit the doctor for the certain idea the voucher is offering, and in this preventive care. So this is a type of innovation that we're trying to put in Bulgaria for the past year.
Я могу добавить к сказанному. У нас в Таджикистане по проекту
Okay, and here in Tajikistan, under the World Bank project for improvement of health services at primary care level, introduced result-based financing. This is motivation of family doctor, family physician to detect in a timely manner patients with diabetes mellitus, with high blood pressure, or any other pathology. There are special indicators for that. And now we've been discussing whether we need to change some of those indicators to be able to identify this pathology at early stages. But the family doctor need to be motivated to do that. If this motivation is in place, we can achieve really great results at the primary care level. However, I would like to approach from a different side. In our countries, Central Asia,
плохо развит институт общественного здравоохранения.
public health institute is very poorly developed. We don't have risk assessment system. We don't have risk management system. And all the system like single payer, like 70%, as our colleague from Bulgaria said, goes to the secondary or hospital care to treatment of patients. And remaining amounts go to pay salary. And preventive healthcare doesn't have any money. An indicator that our colleagues said we also have special indicators for family medicine. They assess assessed and provide additional bonuses to doctors, but people still don't develop yet a culture for health promotion or health saving, and people don't seek in any hospital when they have first signs, because they have to pay, and patients usually go to polyclinic when everything goes bad. And to change this tradition of post-Soviet era is very difficult. It's extremely difficult. And this information is extremely important because we do this information work on a continuous basis at all levels. It is very difficult to reach out people because we have very few people who are responsible for their health. They usually rely on doctors, that doctors rely that patient got sick or died and didn't get health care in time. General aggression against doctors. On one hand, can be beneficial to the state because the state cannot fully finance health services to full extent. For example, we've been introducing neonatal screening for 3 years with very important grade impediments, because we have a lot of problem. We have endemic zone of iodine deficiency, and to understand why we need such important investments in neonatal screening was very difficult to communicate to people. However, when we were able to introduce that, and when we detect up to 40% of patients with thyroid gland disorders, if treat this in time and do substitution therapy, it will be a normal person. And this program is very important for our countries. And in the future, these 40 children we detect in time and that they receive substitution hormonotherapy, they becoming normal members of society. They won't be disabled people, and it's a great burden. And we're able to save a lot of money, burden health sector, because otherwise they will have to be treated in the future. And this type of risk assessment and risk management, unfortunately, is not done properly in our countries. And therefore, we would like our public health to become stronger. And this harm reduction concept that only been initiated in our countries is one of the instruments that will allow to communicate to decision makers and communicate to our people the need to make step-by-step some steps, important steps to improve their health. Because we have many teenagers that smoke and use drugs, and all these manipulations related to the fact that we're being distracted from the main problem, the problem that we have to prevent bad habits. Need to start this in family. Family need to establish basics of healthy lifestyle. If this doesn't happen, obviously our countries will have their high mortality and high
I'm afraid we are running out of time,
indicators.
I don't think we can hear you.
I know it's late, but just this point is important. FCTC provision for harm reduction exists, It's just that various interest groups and governments hide it. If I remember correctly, Article 1D, if I remember, says all measures, appropriate measures to reduce supply, demand, and harm reduction to make people's life healthier. So I think there is a general tendency to hide this harm reduction part from. It is integral part there, and I think, I keep convincing my government, which is of course in South Asia, that no, it exists, because harm reduction is also part of medical care itself. And the FCTC does provide for it, just for information. Thank you.
Thank you very much. Unfortunately, we really ran out of time, so I would like to thank you to our panelists, to our Kadi, and to all of you. And I encourage you to find our guests. Still have questions, just ask them during the coffee break. Thank you.
Yes, yes, we do.
it becomes a bit tedious to share. If you have one more, it would be good.
For one?
Yes, please. And then one in the audience.
So I have already one.
Three here. Thank you, Kamil.
It's good to have you. One in the audience.
Thank you so much, Kamil. Shall we start in a minute? Can you get people from outside to come in?
How's it going to do that?
Yeah. Would you mind chasing people from outside to come in? Otherwise, they'll not come in.
Just announce it.
I have to get the ring.
I know. Get somebody. In a minute.
Plastic. Loads of plastic. They're real. Oh. It's poor plastic, cheap plastic.
Good morning, everybody. And thank you so much for coming on time. I really appreciate you all being here. Good morning, everybody. And thanks for coming here for this session. It's exciting to be at the GFN for many reasons, as you always know. It is very enriching and insightful, but also we hope in this particular session, which is tobacco industry transformation reaching LMICs, low and middle income countries, is the focus of the conversation. And I'm hoping that it gives us enough prompts, enough motivation to take into the conference and beyond in terms of actionable items. So on that note, I want to just say one thing about the field that we are in. I do not think there is any doubt or debate that reduced risk products should be available and accessible to consumers of risky forms of tobacco products in LMICs. I hope that is an absolutely accepted point. However, we know for a fact that if you were to travel in Europe, which you are in now, go to America, in Northern America, you will see the availability of a range of reduced risk products. And by that, I very clearly mean heated tobacco products, electronic cigarettes or vapes, and nicotine pouches and snus. If you were to travel in the world of LMICs, on the other hand, you may not see that. Having said that, the fact remains that nearly 80% of consumers of risky forms of tobacco live currently in LMICs. And before anyone starts wondering why does Sud, by the way, I'm Sud Patwardhan, just in case, why does Sud keep on talking about risky forms of tobacco products? I'm very conscious that we do not want to just harp on about smoked or combustible forms of tobacco. Yeah. There are parts of the world where a significant number of people consume smokeless tobacco products, especially South Asia and in Africa and Southeast Asia, where those products cause comparable harm because of their consumption among the consumers who use them. So, and hence the less risky forms of tobacco and nicotine products, and hence risky forms of tobacco products. So I'm trying to make that distinction very clearly from the outset, and you will see why it's important when we start talking to some of the excellent panelists who have agreed to be on the panel. So the idea is that we have experts from the consumer world, from tobacco control world, from the corporate world. We cannot leave companies and industry out of this conversation. We shouldn't. It's at our own peril. And someone who has come from a management world, understanding strategy, but also the business case for why or why not, and whether companies should be transforming in a much broader way to meet consumer needs in LMICs. So that's the panel composition. You can look at your program to see about their detailed careers, but they're all excellent people from different disciplines who have converged here at JFN to be part of this workshop. So without further ado, I want to start with a consumer viewpoint, but also not just consumer viewpoint, a viewpoint coming from years of working in the tobacco control space in a country such as Kenya. And that's where I would like Joseph to use perhaps 3 to 5 minutes to kind of paint a very top-line picture of what he has seen in his years of work in this, what may be the challenges he's seeing and facing. And then, of course, we'll go through this initial round of initial opening lines by each of the panelists. And then I will be asking some questions to all of them after that, following which I would love to hear much more active participation from all of you. So that's going to be the flow. Joseph, all yours, my friend.
Thank you. Thank you very much, Sud, for having me here. So I'll just speak briefly on the challenges we are facing in Kenya and Africa as a continent where at the moment we have about 77 million smokers on the continent. We have about 250,000 of them who die from smoking-related diseases. So mine here is just to learn and to ask what the industry is doing, because they're actively on the continent, and we at the moment cannot afford cessation services and products recommended by WHO, which are nicotine gum and nicotine patches, which cost about $50 to $45, and most smokers on the continent cannot afford that. So mine is just to learn what the industry is doing to help us, because smokers are willing to switch, and we keep hearing about these products on the internet and on social media happening in Sweden and other countries like England, but we have no access to these products. So mine is just to find out what they're doing for us.
That's a great way to open the discussion, which we will definitely come to. And Joseph, thanks for highlighting the need of not just 77 million users today, but it is, I believe, one of the fastest, quickest growing markets for tobacco companies for their combustible products. So let's not forget that this is not just for today's consumers, but also future potential consumers of risky forms of tobacco. Thank you so much, Joseph. I'm going to switch gears and go to Atul. And Atul, you come from a very interesting, rich background that has taken you across multiple continents, 3 at least at last count, including a stint at MIT and Boston Consulting Group, and working at least 2 specific things where I think your supply chain expertise, coffee and tobacco, might be of interest for the audiences to understand how does tobacco industry transformation fit with what LMICs can get from these companies, and whether there is a win-win there or not. So Atul, please.
Thank you, sir.
Take the mic. Nothing, just speak into it if you can.
Can you hear me all right?
No.
Can you hear me all right? Yeah, thank you so much. So it's interesting, Sud said in his opening remarks that if you go to the US, you will see a broad range of reduced risk products. If you go to India, you will equally see a broad range of risky products, right? From cigarettes to bidis to gutkhas to canny to snuff and even areca nut products, right? So there's a whole range of risky products. And when Joseph was opening his remarks, right? I mean, it is absolutely clear that consumers all around the world are demanding a reduced risk product, right? I mean, it is They may not express it all around the world, but that unexpressed need is very, very strong. And it is also a fact that most tobacco companies have significant revenue and profit source from the LMICs, from low and medium income countries, whether you look at India, Indonesia, or, many countries in Africa, many countries in South America. So it's a big source for tobacco companies in terms of revenue and profit. And the other factor is that of course there is the FCTC guidelines and everything, but these countries also have limited capacity or capability, and of course it varies across the country to enforce those guidelines, right? So there's a bit of a regulatory uncertainty in this market, which also impacts commitment from the tobacco companies, right? So the one thing that corporations don't like is uncertainty, whether it's the economic uncertainty or the regulation uncertainty. So the fact that the regulation rollout is also not consistent across the world impacts the availability of the products, right? But if you look at from the capability point of view, right, you see that in many LMICs, there is an absolutely strong structure to bring these products with great speed, right? I mean, let's take the example of India, right? I mean, you got very strong consumer-backed supply chain, right? Right from outlets to channels to market, distribution, manufacturing, product design, packaging, raw material sources. In fact, most of the nicotine, and correct me if I'm wrong, most of the nicotine globally gets sourced from LMICs, right? So the structure is there. And to me, as an observer from outside, you see this kind of a K-shaped profile. You see this very, very strong take-up in the developed world, but on equally you see no take-up or very little take-up in the developing world. And I think what is expedient for this panel is to interrogate as to why that's happening. I mean, what are the critical questions that come to our mind? I mean, I can put forward 5 questions if I may, but there must be many more, and then we can collectively debate as to how do we bring this to life. I mean, the first question I have is, what business facilitators or catalyst do we need to see in LMIC which will motivate tobacco companies and the governments, right, and the consumers, the whole ecosystem, to have a broad availability of reduced risk products? What are those catalysts and facilitators that we would like to see in the LMIC? The second question that comes to my mind is, what is the decision matrix that companies are looking as they roll out these products around the world, right? I mean, launching new products for the consumer sector is a very expensive proposition.
I would like you to finish that line, but that's very tempting for us and a very good segue into what the industry may want to respond to.
Yeah.
Please finish that, sorry.
Okay, no, this is great. And you also often see that in many of the LMICs, where it is legal to sell the products, still those products are not available. So need to understand, what is the reluctance, right? We've got everything there. So, you've got the legal framework, you've got the regulatory framework, you apparently have the consumer needs. So, what is the reluctance in launching products where it is absolutely legal to do so? And the final question I would like to ask is that what are the success stories in the tobacco industry and outside the tobacco industry, right? What are the exemplars? What are the stories that we can relate to and we can learn from and help a quick launch of those products? So, so look forward to the conversation.
First of all, thank you so much, Atul. You've listed out a range of questions which definitely will stimulate a great discussion today, and thanks for bringing that perspective, which goes well beyond just a pure industry transformation. There's a lot of parallels, a lot of learnings which we should try and tap into. A very vivid picture you painted, which I want to just kind of put it out here now before I move to Flora, is the fact that those who have traveled to India, for example, or are from India would note that the range of tobacco products that are available, all risky, mind you, are phenomenal and quite saddening. But if you go to a local, what's called a pawn shop or a corner shop, they're all there for display. Yeah, so of course, there was a point made by Atul earlier about FCTC and the implementation or the lack thereof is something to discuss in our panel going forward. But I want to hear from Flora, who is a very senior executive at British American Tobacco, has done roles in Western Africa in senior leadership roles and in the corporate headquarters of British American Tobacco and in America. So Flora, tobacco industry transformation, what's happening at BAT? What can you tell us about and what are your views about it?
I hope I'm not the only one who's going to answer all those questions. Thank you, GFN, for the opportunity. What I need to say on the outset is this. LMICs, when I reference them, I'm looking at those 137 countries that the World Bank has said are LMICs. And I hope those are the countries that you are looking at. The first thing is the transformation. We asked the question, why is it not reaching where it's supposed to? Before I answer that question, I want to be clear from our perspective, when BAT says transformation, what we actually mean, because sometimes it might mean something different to ordinary people. A few years back, our company revisited our purpose and determined that the way to move forward is to focus on developing products that in the future or today, people who continue to use nicotine will have a safer options to use. And we concluded that that would be the best way to improve, or how do I say, the societal expectation to make an impact in the negative impact of our business, to improve the health impact of our business. And I can tell you, that led to a lot of actions in the company to develop these products. This is why the variety of products that you see that are safer is due to the investment that was made in science, in technology, and innovation, and it continues to happen. But the transformation is not just on safer products. It's a whole change in the organization, a change in behavior, a change in attitude. I need to say this because yesterday I listened and picked up this sentiment. It is still, when you reference the tobacco company, a lot of people still think of the tobacco company of 50 years ago. It is no longer like that. In fact, part of the transformation is the way we manage our waste, our resource, our water, our supply chain, our value chain, the way we manage our talent. It's interesting. If you looked at the announcement made recently on BAT, because there was a change in the CEO, it struck me personally that the highlight of what this new person have done was the reference to his team leadership and collaboration with talent and inclusion with talent. 20 years ago when I joined this industry, it probably would have been on his track record on volume and shares. Things have changed, and that is what we look at when we say transformation, and it will continue to be. Now, talking about going back to the product, safer product, and where it is launched. Today in BAT, we have launched this variety of products in 60 markets. 36 of those markets are vapor markets. 28 modern oral, and our tobacco-heated device. With respect to LMSCs, for instance, okay, are we where we are supposed, or where it ought to be, or where everybody would like it to be everywhere? Obviously, the safer products in our concept, is universal. I believe in health equity, and therefore, technically, it should be available access to everyone. However, that is not reality, is it? In the 60 markets that we have, in fact, the top 12 THP market, THP, I mean tobacco heating market, 4 of them are actually in LICs. Pakistan, for instance, is now the 3rd biggest market when it comes to modern oral. Colombia, Peru, Bangladesh, Uzbekistan, these are all LMC countries. These are established vapor markets. In fact, today, Kenya and South Africa are being piloted. I am glad that you came from Kenya. If it wasn't for the pushback on regulation, modern oral will be in the 21 COMESA markets today. But that couldn't happen because of the regulatory pushback. You asked, what are the considerations when you are trying to launch? There are several things. This is a commercial start. Apart from the regulatory framework, which we probably should come back to, there's also issues with cost, with pricing, with the local consumer taste, with knowledge. There is, if you think about it, there are challenges. A lot of the LMC countries, to be honest with you, have priorities, health priorities that go beyond thinking about smokers. I can tell you that 16 of those countries probably have smoking prevalence that are less than 10 or less than 5. But they have high incidence of child death, traffic death, sanitary issues that kill cholera and malaria. And so thinking that they're going to focus on few smokers and not these priority issues is a little bit. So there are challenges that push back, and I'm happy to revisit them. But all I can say is I have told you where BAT has launched. There's also our competitors who also have presence in their own product. By the time you put it all, it might not be as much as you desire, but we are making great progress. And there is plan in the next 2 years to launch in another 60 markets. So we are progressing.
Flora, thank you so much. That's a very comprehensive review. In fact, this is great to hear from the companies, one example of a company which you represent regarding what is being done. I would definitely love to drill down into some of the challenges you face and some of the thinking. And as well, I would like to then bring the panel together to kind of start having a discussion. Well, is it really the case, and this is where I will look at Atul, really the case that because price plays a role, but then is there any role for a much mass scale market for current consumers? So there's a bunch of things to pick on what you've said. The regulatory framework, and I would love to hear about how, what was the challenge, if you can talk about it, the COMESA challenge, which brings me to Joseph in a very circular fashion. Joseph, Flora mentioned the launch of nicotine pouches, modern oral as you call it, but nicotine pouches, if I was to call it that way. Yes, thank you. In Kenya, we have watched it from the periphery. Folks here might have seen for the last couple of years, a lot of ups and downs, a lot of news. Of course, sitting in London or in India, I would not necessarily know what is going on. Would you be able to sort of shed some light from what you have seen happening there, and any learnings perhaps from a consumer, from a tobacco control point of view, but also now that you're part of a broader tobacco harm reduction community, what is there for us to learn if we were to do the same thing again somewhere else?
Well, first, I think the fact that the industry is trying to launch products in the country is a win for public health, and we support that 100%. However, I will take a small issue in the way the product was launched, in the sense that, yes, we do advocate for nicotine pouches to be made available, but the way the product was launched and how it was displayed in the shops was really one thing, because they sort of put it, it looks like a Christmas tree, and you have pouches all over the place, and and so the backlash does not fall on the industry, it falls on the advocates. So we're here trying to promote these new alternatives, but the way they've been brought into the market is also wanting to some extent. And I did take issue with that, but again, the fact that the industry is trying is really a win for public health, and I would encourage other key players to also come into the market and try and bring in new varieties of products. The challenge we're facing in Kenya is that, yes, we do have a Nicotine Control Act, but we should mimic the Swedish experience and try maybe and begin to explore ways to look for a Nicotine Act that is separate, that deals with the standards and with the advertising and things of that nature. And if we can engage policymakers and doctors and people, stakeholders, and I think we can make bigger strides than we are at the moment.
I want to pick on that point. Don't keep your mic yet. I may have another question to follow up. I'm so glad you have kind of put some light on what was not very visible outside, that and unless you're on the ground, you wouldn't know that the way the product has been launched is perhaps done in a way that is going to ruffle some feathers as such. What could have been done differently? I always, and this is going back to my days in pharmaceuticals, and there is this concept of market conditioning, where you work with the stakeholders in the market, you work with the various range of, starting from consumers, but also doctors and all the ones you mentioned. Is that something they could have done? Is that something you are doing? Is there any way out of all this?
Well, that's a bit tough. I think just my opinion, what I think should have been done is perhaps maybe start with small steps and try introduce the product as a pharmaceutical product. I know it's supposed to be a consumer product, but if we had followed the right channels and maybe just put it where we have cessation products on the same stores, it would have been absorbed much easier, and there wouldn't have been a lot of noise made in the media about it. Yeah.
Now look, this is a panel to discuss and throw ideas and have very different views, and they're all respected and welcomed, and that's the whole idea. So thank you so much for that. I want to pick on something related to what you said, Atul. There are two things that got my attention. I don't know if the audience was listening, but I'm going to pick on those two things to kind of drill down. One is the what is it? K-shaped, K-curve, K-what?
Yeah, sorry for throwing that term, right? I mean, there is, I've got some muscle memory of being a former consultant, so apologies if I've just thrown a term. I mean, what it's referring to is, you've got a very fast take-up in the developed world and a very low take-up. So it almost looks like the alphabet K, nothing more than that. It sounds more complicated than it is. So it's it's just a visual representation of what's happening in the marketplace, right?
No, for sure. That's very helpful, actually. And that kind of leads to another thing you said about consumer-back supply chain.
Yeah.
I would love to understand more, because I think there is something there that perhaps I have missed over the years of understanding what RRPs need in terms of reaching the right audiences.
Yeah, I mean, to some extent, I mean, the companies like BAT have been immensely successful in designing consumer-backed supply chain. What I really mean is that, the traditional view of the supply chain is that you develop products, you invent products, and you kind of build a business model to reach to the consumer. What we need for RRP is just the reverse, right? You try to take it from a perspective of consumer and design the supply chain backwards, right? So understanding how the consumer buys the products, what are the considerations when they buy the product, how do they consume the products, what are the occasions of consumption, then you design the product accordingly, then you design the channels to market. Would they like to go to a shop and buy, like the pawn shop Sudh was alluding to, or would they like to buy online? So you kind of create the channels of market, and you go backwards into the supply chain and design distribution and manufacturing and raw material sourcing. I think I'm not advocating that the product forward or the consumer back is which one is better, but it just intuitively feels to me that for reduced risk products, a consumer back supply chain design is going to be quite powerful, and the industry is already adopting that, in my view, which is very heartening to note. Yeah.
Thank you so much for that. For me, it's a great education in the context of how products are designed and where the kind of origin of the idea is, whether it's consumer demand, and as you said, there is no right or wrong. I would like to perhaps highlight over the last 10 years of GFN, I'm sure we have come here, many of us have for the last all 10 years, and we talk about some of the products that are currently considered reduced risk products to be almost a panacea for all the smokers in the world. It's often kind of just glibly mentioned, yeah, so this is for all the, and these markets and these countries don't allow it. And oftentimes I think, hang on, but have you actually gone on the streets of Pakistan and Indonesia and seen whether your product that you think is a reduced risk product actually meets the needs of that consumer? Can that consumer afford it? Do they care about it? And I think what struck me as and I'm not being unfair and biased, but I think it was an interesting insight when I saw that you guys had launched the pan masala flavored nicotine pouches in Pakistan. That I think is listening to the consumers, trying to meet them where they are. I appreciate that level of consumer insight and consumer reach. Now, before jumping into that, Flora, I thought it's also very interesting what you mentioned about transformation not being just a word. It's a cultural change, it's a behavioral change, attitude change, people change, and products become part of that change. That's quite enlightening. Now, you mentioned regulatory frameworks. What do you mean by regulatory frameworks, and where do you think are the biggest challenges you've faced with regards to RRPs and LMICs?
Okay, so if you let me step back a little. If we look at what has happened, so far, our efforts have shown that 22 million of our smoking population have already switched to new products, new alternative reduced risk product. And we anticipate that in another 7 years, this will reach to 50 million. We are on our way to doing that. There must be what enabled that growth to happen. That is not enabling when it comes to some of the LMC countries that I mentioned to you, that there are some challenges. If I tell you regulatory challenges, for instance, if I look at the 136 countries of focus that we're discussing, 26 of them has already banned vapor. 60% of those countries do not have regulation at all. And it doesn't mean that you can jump in there and launch because they don't. And places, big ones, Argentina, Brazil, Thailand, Egypt, a lot of these places have also closed their doors to these new products. So as long as those doors are closed, nothing is going to happen there. And the other thing, it was remarkable to see, and I'm happy to provide references, that if there's a survey that was conducted in Indonesia and India, that a quarter of the people that smoke believe that if you stop smoking, you can actually harm your health. 12% of the smoking population in India said they were not aware of e-cigarette. And a third of Indonesians said they don't know what reduced risk products are. So there is a huge lack of either misinformation or lack of knowledge. And when I said part of the consideration for launching is appreciation of the product where these countries are. So there is a lot of challenges that are not just availability of products that happens, but regulation. If I were, and I'm not, if I were a regulator and I believe in harm reduction, I will put a policy framework that will enable and encourage companies to even innovate, even better products, even safer products, to continue in the trade. That is what people do in other consumer goods. I will put in place a policy framework that will incentivize even someone who is not thinking about switching to switch. It could be pricing and costing, as you say. It could be a preference in taste. It could be whatever it is, just to incentivize people to move. But I will also use technology and education to address issues of youth uptake. We can't forget that because this is all part of the whole scenario. And also puts resources for enforcement. It's one thing to put regulation, but it's also another one to ensure that it is done. There are a few things that could be done from a regulatory perspective that will address some of the issues and challenges that I have said that we are facing.
Well, that's a very comprehensive review, and I think that sort of a regulatory framework as against prohibition is something that I think is not often talked about, at least in the relevant conferences and events, and it remains to be seen how that reaches first to the policymakers instead of a prohibitionist kind of agenda-driven, ideological-driven anti-industry, anti-product stance, which is actually to the detriment of the consumers ultimately. Atul, you wanted to say something? Yeah.
Sorry if I'm borrow the mic. So I just wanted to talk about the price and the cost, right? So when you're talking about the developing world, the scale economics are completely different, right? So for example, what a bicycle would cost in London, you can probably buy a new car in London, in India, right? So, the scale economics are completely different. And, also let's not forget, right? So all the raw materials are fundamentally coming from the LMICs. So, and that is true with the existing products also, right? I mean, the cost of an equivalent cigarette, for example, or a pack of cigarettes in the UK is a lot more expensive than what you would find in the developing world. So, there's no reason why we can't make these products affordable, right? Of course, there is a business case. There is, all this, the discounted cash flow, etc., that the companies need to do. So that's one point I wanted to allude to. And there's another point I wanted to say is that, how do we measure a successful availability of reduced risk product? Is it equivalent, finding a ratio of sticks equivalent of RRPs in the market, right? And what is the percentage of that around the world, right? So, of course, we might say that we've launched these products in X number of markets, but how does it compare in terms of ratios, right? That's quite and at what price points, right? I mean, that's quite critical.
That's very helpful. I'm going to just zoom back into what I like to always write about and talk about, which is the 4 A's. And let me think if I get right. So the affordability, accessibility, availability, and appeal of adult-oriented reduced risk products. There's a lot of A's there and a lot of alphabets and words. But the point is, these are quite a few things to take. And Joseph, what you said really struck a chord with me. I thought that for years, despite the FCTC, despite Article 14 of the FCTC stating that there is a need to roll out tobacco dependence treatment, and there is a need for, and it's in the model list of medicines of the WHO that nicotine replacement therapy is there, but it's not available at the price point that an average smoker in Kenya would afford. Is that?
No, it's not available. Like I said, gums and patches go for about $50.
Yeah.
I've tried them before myself.
And a cigarette pack?
About $7, $5.
This is not dissimilar to what I've seen in India. In fact, I remember going to a pharmacy in Dhaka in Bangladesh and was shocked because they were shocked to even hear the word nicotine replacement therapy. They didn't even know what it was. They scrambled around, like, oh, let me go and look back. This was one of the biggest pharmacies in Dhaka. So forget the remote interiors. And so I want to turn this on its head and then kind of go to the audience because I would love to hear some specific inputs that I'm going to point to people, unfortunately, but also with the broader audience. I think there's an opportunity here where for some reason, those who manufacture nicotine replacement or have done over the years have not taken it as a cause for them to make available cheaper, affordable nicotine replacement at all locations where cigarettes or other oral tobacco products are available. That's a missed opportunity. And if I was to look at you, Flora, and as a representative of the industry broadly, I would say, look, you have an opportunity to kind of take a higher moral ground for the right commercial reasons and make available RRPs instead of the risky products that are currently sold and reach those audiences, those consumers. But let me then kind of take a slightly different tack. There was work done funded by the Foundation for a Smoke-Free World that I'm aware of, and there were a bunch of people I'm sure here. I can see Peter, there's Amir, and I don't mean to sort of put you in a difficult spot, but if you don't mind talking about the work that Euromonitor and Peter through Idwala did in terms of analyzing data for the transformation index, specifically about LMIC. So this is not about the broad index. I would love to see if there were learnings from that kind of tie up better with what we are talking about here. So maybe, I don't know, Amir, because you generated the data, and then Peter, because you analyzed it. So Amir first, would you mind saying something about it? We can get a mic to you straight away. So just first name and a few lines, please. Thank you.
Hi, thank you. Yeah, Amir from Euromonitor International. I'm here with my colleague, Idra. So we are the index research partner for the Tobacco Transformation Index, which is funded by the Foundation for a Smoke-Free World. What we do there is really, I think one of the main things which is relevant is the country fact sheet that we put together, so that looks at 36 countries where we've got the most prevalence really of nicotine and tobacco usage, and we're sort of mapping out the legislation there. So to Flora's point, in a lot of countries it's banned, etc. So yeah, I think that's probably something that might be relevant for people to look at, which is on the index website.
Thank you, Amir. That's a great start. People can go and refer to that. I think there is some level of analysis, Peter, I'm hoping that you can perhaps touch upon in terms of the companies that you looked at within the index. Because from what I saw, I thought, wow, there are those who are leading the pack, and you would sort of expect to see them. But then there are those who are not necessarily there. And I would say tobacco industry transformation cannot be just a responsibility of the international players. Yeah, there has to be a locally driven national companies also have to take the role. So can you, or would you like to shed some light on that? Can I have the mic here, please? So just in a few lines, please, Peter. Thank you.
Thank you. So, Peter from Idwala Research. I think I don't want to go into the specific data. I mean, Amir has mentioned that one of the things that they publish specifically, or that is an area that they measure, is the number of countries where these products are available. They also look at the number of products in each country, which to some extent is a bit of a blunt instrument, because one country can be recorded as being present without a significant amount of products being sold. Nevertheless, I think when you look at the multinationals, as Sudha said, there's a fairly broad representation. I think when you start looking at the other individual companies, it becomes an issue of regulation, where you have single country companies, they don't necessarily go abroad, and I think the focus is not necessarily to do that, but very often these products are not allowed in those countries. And then if you lay on top of that what the excise structures are in those markets, it becomes problematic from a cost point of view to introduce these products. But certainly when you look at the overall, if you look at the scores of the companies and where and correlate that to their transformation scores, it's quite obvious that the multinational public companies score the highest. The privately owned single country companies really score the lowest on quite a lot of measures, and somewhere in between sits sort of listed single country and private multinational. But it's very clear that where you have public scrutiny, international companies, certainly those companies score much higher on the transformation index.
That's a very interesting. Thank you so much, first of all, for talking about this on the spot and kind of illuminating this. I think the difference that you're highlighting. Let me pick an example, and please, they may be better experts at this. But Indonesia, for example, with Gunung Garam, unless things have changed, they have not ratified the FCTC, right, as a country. So now what does that mean? Is there a connection? There may not be. I'm just trying to sort of raise this conversation. I would love to start getting some inputs from the audience on, is there a correlation where countries have not signed up to something and the basic tobacco control things have not been sort of put in place? I know in some places tobacco control can go over the top and their resistance to RRPs is quite worrisome, let me say that officially. But in some countries, tobacco control has not even gone there. Does that mean that the companies there, the one I mentioned, for example, in Indonesia, may not have the pressure for transforming? There is no need to. We continue doing our business and we can continue. Who are you to ask us? Is that what may be happening? And can I have some people sort of start throwing some insight if they have, or at least some challenges that, or how to overcome this even? Please. Oh, come on. Yeah, Rajesh. Wait for a mic and introduce yourself, please. And you can look at me because they're going to show you from the screen.
Yeah, so I mean, I think one of the reasons I feel the transformation is not happening in countries where the provisions are already implemented, I think is the synonymous use of terms nicotine, tobacco, smokeless tobacco, and everything. And I think the medical communities also miss it. And very blatant, I mean, it's a very shockingly alarming when we did our own studies in India and elsewhere. So I would think that when companies, whether global or local, look at transformation as a tool, they ought to not ignore this fact that the awareness to nicotine and what nicotine is, what else makes it dirty, that in the dirty products. So, I mean, that distinction has to start with the medical communities, the healthcare providers, and then percolate down. That is something that I feel is not happening enough.
Thank you so much. I think that, why don't you comment on that?
Yeah, I was just saying that broadly I agree with that because this is what I was referring to as to lack of knowledge or misinformation, and everyone needs to, when I say everyone, whoever is in the sector need to recognize this and they need to address it. It really is shocking to see that we might be talking about why is this not being launched here, why, and yet the number of people who don't even want to think about reduced risk product that should be thinking about it. BAT has, it's almost like a foot on the door in India. If the regulation were to be different, that country, even if it's just to replace smokeless product with safer ones, it could happen overnight and quickly to a large population. But that can happen, and it has nothing to do with perhaps they are over there or any of the issues that we have raised. But I do agree with you that lack of knowledge, misinformation, and training and awareness is something that should be part of that agenda. But remember, some of these companies and in some countries, you can't even communicate directly with your consumers. So it comes back. I'm not saying everywhere, but significant part of that, you couldn't. So the communication and the awareness, while I think the industry should contribute in creating the content of this communication, because we do know a lot about the products. But because of the limitation put by maybe policies, the driver of that knowledge building probably relies somewhere else, people like Sud and the medical people.
Sorry, just a question. Has the industry considered equipping advocates, because we have advocates across the continent who have knowledge about this stuff, but we're not able to carry out research and awareness campaigns simply due to lack of resources, if I may say. We've tried to apply to Bloomberg and other CTFK organizations, and they cannot listen to us because we're including harm reduction. So is the industry looking at maybe giving opportunities to various harm reduction, tobacco harm reduction organizations?
To be honest, if I speak personally to answer your question personally, the industry, or at least BAT, would be willing, as I say, to contribute in any way that ensures that there is a correction. But just remember, as soon as the industry gives you a penny to help you to do that, you are cancelled. Whatever you say is no longer credible because and this goes back to what I was saying about changing and regarding the industry as the baggage that you are carrying. So if you do, you're castigated. If you don't, you're castigated. So, but that has to change because the future and nicotine belongs to all of us. And we really have to forget about division and finger pointing and come together to find a way to turn something that is negative into a positive future, I think. We have to stoop to conquer, and we need to do it collectively. Blaming the industry or one person or the other really doesn't accelerate tobacco harm reduction.
Well, thank you so much for that question, Joseph, because, and thanks for the very, very clear, sharp response, Flora. I think it's helpful to remind ourselves, starting with Rajesh talking about nicotine illiteracy among key stakeholders, to how that can be addressed and what are the resources available. What I can just chip in is saying some of the learnings we've had in our work in the last 4 years in the UK with mental health practitioners or professionals, and in India with very structural, fundamental training of healthcare practitioners is, it is a long haul. It takes a lot of effort. It has to be done by credible peers who will talk about nicotine and build that essential nicotine confidence. I do not want to be saying that this is the excuse for not launching, but I think it's definitely a reason why in some countries the regulatory framework that you desire is not going to be there, because there is still that confusion about nicotine and tobacco and smoking and smokeless and cancer. So that remains a problem. I think the more such forums or fora allow us to have that conversation and bring more people together and then go and actually do something on the ground, allows us to be action-oriented and result-oriented. That was a great comment, Rajesh. Thank you so much. Clive, you want to say something?
Yeah, Clive Bates. I think we should get away from thinking of the concept of industry transformation as if it's one industry, you know, the sort of big tobacco of legend. The industry is extremely heterogeneous, and in particular, there is a huge difference between the multinationals like BAT, PMI, JTI, Imperial, and the state-owned tobacco monopolies, which actually dominate the tobacco industry worldwide. And I think there's resistance to transformation for rather crude competitive reasons. The incumbent tobacco model, the incumbent tobacco monopolists and state-owned companies simply don't have the products to compete in vaping, in heated tobacco products, in new nicotine pouches. So their interests are using their leverage with the state to keep these products at bay. And to use their influence with FCTC delegations to keep a hostile environment for these products. Otherwise, they'll find that BAT, PMI, and so on are eating into their share, pushing aside their market. So I think we need to stop thinking about the industry as one thing. There are differences between the main multinational companies, and there are huge differences between the main multinational companies and the state-owned and local monopolies. And they have very different interests, and the state-owned monopolies are a major barrier to industry-wide transformation, in my opinion.
Thank you so much for that, Clive. Sorry, you want to comment something on that?
Yeah, I think that's a very good addition to make. And in addition to, just as he was saying about whose other interest towards the progress that is being made, if I look at, again, at the LMICs that we're looking at, the WHO has such influence and trust and credibility in these countries because of the systems they create, the health programs they do, and communication. And at the same time, they are also keen to tell this government not to allow reduced-risk products. And why would they not listen to them and listen to us? That's, again, another intervention that creates a challenge.
No, I think, look, the complex ecosystem that we live in, where in a strange, ironical way, there's a bunch of folks who have agendas against tobacco harm reduction almost come together without knowing. You know, there's the sort of intergovernmental forces or above governmental forces like the ones you mentioned. There's the state monopolies that you mentioned, Clive, and I think there is a strange kind of unspoken alignment there, which is to the detriment of the consumers locally. John.
Hi, it's John Fell from the UK. I want to ask a kind of complementary questions to Clive's, really, because we're used to thinking about industry transformation, as Clive said, in terms of the big tobacco companies, whether they're state-owned or multinationals. And when there were only cigarettes or traditional tobacco products available, the supply chains were limited, so it was only those guys competing. But in the new world, we've got vapes, we've got pouches. A lot of LMICs have very entrepreneurial business cultures, traders who are used to getting products out in front of people from all sorts of sources. Do you think there's a role for that in this debate, in terms of those products being put in front of consumers through new supply chains? Is that a good thing? Is it problematic? Could those companies actually, or could that route encourage and keep snapping at the heels of the multinationals to make sure they're trying as hard as they can in these places?
That's a great question. Sorry, I thought you wanted to ask this to Clive. Is that right or not?
No, it's to the panel generally.
I passed the mic to Clive for no reason. Sorry, Clive. Don't ignore me. Atul, do you want to take this on? Because from a supply chain point of view, you're talking about disruption, really, of how products are available at the point of sale.
Yes.
Yeah.
No, absolutely right. So the innovation can't be the purview of the few. And, more widespread innovation you have, of course, under the framework of regulation, that's very important, right? Because we need to be sure that these products are designed and manufactured and distributed and sold as per accepted standards and guidelines. And, if you look at any of the launches that have happened for some of the very popular products that we use, right? It's distributed innovation that gets consolidated after some time, right? And the tobacco industry apparently started the same way 120 years ago. So why can't we adopt the same model now, right?
Yeah, I'm going to just push back a bit because I know that it's very tempting to look at disruptive models, and for sure that's the way we work and live today, and buying things online, for example, would be a way of doing it. But we also have to learn from what you've seen in the US, where unfettered access to those who shouldn't have access to the advertising and the continuous promotion of products has led to definitely a moral panic, and perhaps data may show that they were more than who should have taken up the products, and it was not intended for them. So there is a balance, right? Again, that's where the regulatory frameworks, Flora, you talk about come handy, because they're going to ensure that it is for the intended audiences, intended consumers. And it's easy to say, of course, the regulatory sweet spot is not easy to find. Ben, do you want to make a comment? And then there's Jose after that.
Yes, I'm Bengt Wiberg from Sweden, founder of EU for Snus and also inventor of a new pouch technology. I think Flora said something which is extremely important. She mentioned regulation. And what is, if not, the biggest problem why we are not seeing the Swedish experience with the lowest rate of smoking, the lowest rates of tobacco harm? Why don't we see that in the rest of the world? I think because of total lack of regulation, it is a deterrent for the industry to launch safer products if there's no regulation. There's a big uncertainty. In Sweden, last year came an extremely intelligent regulation regulating all tobacco-free nicotine products, such as e-cigarettes, nicotine pouches, and the regulation even covers products that are not yet invented. It's like a Bible of 600 pages. It still has not been translated to English, just a summary. So my suggestion to the panel, can we, by exporting, sort of say, the very comprehensive Swedish regulations to other countries, instead of every country inventing the wheel, so to say, again?
Thank you so much, Bent. Shall we? We have two more people, actually. The gentleman behind Stephanie there, sorry. And then Jose after that, sorry. Please.
Thank you. My name is Alexander Nussbaum. I'm the scientific spokesperson at Philip Morris Germany since 2016. I would like to comment on your earlier discussion about the cost of pharmaceutical nicotine replacement therapies. In Germany, we don't have reimbursement of these therapies, and I think we all agree that if you distribute these products at a lower price or reimbursed completely, you get more quitting attempts, and I think in studies also maybe a doubling of success. However, I would like, there's a danger in focusing on this question, I think, and you lose the smoker out of sight, because in Germany, for example, we've done surveys on the barriers of smoking cessation and also of switching, and this was a topic of Professor Glover's workshop this morning, where we asked smokers, 1,000 smokers in 2021 and 1,000 in 2022, and we have a 5-minute video here, and we have a paper on chaos. You can look at it. There we see this is a very minor barrier to smoking cessation for smokers. In Germany, we have 35% smoking prevalence, and less than 10% seriously try to quit per year. So I think the question of the nicotine replacement therapies, the cost, is actually an argument for harm reduction. We need these additional tools and to complement what we have. Try everything, get everything to the smoker that we can, including, of course, the pharmaceutical products. But I think this just shows that there is a need for something else, and the smokers need replacement.
Thank you so much for that comment. Jose, and look, I'm going to just try and close this after Jose's comment, unless there is any more, because we want to have one line each before we close. So, Jose, quick one, please.
The first is to go back to the beginning. You spoke about a risk-reduced product, and then you say the products in India are risky products. It might be better to be consistent if you talk about reduced risk and talk about high risk, so that there's consistency in the language, and it could be educational to the communities to know that these are not without risk, but the risk is reduced. The second question is this issue about transforming industry. Part of the confusion for society is that you have this industry that is transforming, but they are still the major producers of the high-risk product. How do we get to a point where there is separation between production of high-risk product and production of reduced-risk product? Because, it's very difficult to talk about a reformed pedophile that can now be given permission to run a kindergarten. So if we get a clear separation, it might begin to build trust, where the RRP companies become RRP independent companies. When you look at the story of Sweden, I'm intrigued by the fact that those that decided to produce snus at some point decided to sell the cigarette business, so they could concentrate on the non-combustible product. So I think there's room to have that discussion, because it would begin to go back to what Clive was going about, so where you can isolate those that are still producing the high-risk product and be able to say, we have a new core now that is concentrating on RRPs, because it might improve the levels of trust.
Thank you so much, Jose. This is very helpful. I think, look, it's important to have different viewpoints. Not everyone may agree or not agree with that, and that's absolutely fine. That's the way this works. I know that we have literally 11 minutes, and what I would like, Flora, I'm very happy for you to pick up or try and answer anything that you want to from what Jose said or others said, but maybe that's part of the wrap-up kind of line. If I was to start with Joseph, for you to, having sat through this panel, thought about this, specifically answer something about, so what next in terms of you as a consumer, you as an advocate in Kenya, but not just Kenya, in Africa and beyond. What is it that you are going to go and do to ensure that that's going to enable more people who are currently consuming high-risk products, I've said that, high-risk tobacco products, to be able to access safer nicotine products? What are you going to do personally? What's your agenda?
As an advocate, I think for me, my next step is to try and introduce a nicotine act that is separate from a Tobacco Control Act. I think that should be a step in the right direction. Secondly, also as Hosi has said, I think it would be a brilliant idea to have companies that have not sold cigarettes before to be the ones that are introducing these products in the market. It would work much faster.
Thank you so much. And look, again, there is no right or wrong answer. This is what you're going to pursue, and all the best for your plans. Atul, if I may go to you next, just because that's the sequence we have followed. And if you want to tell specifically about areas where you talk about supply chains, you talk about transformation in terms of countries, LMICs, where the product is currently not available because it's very costly or it's not seen as a profitable one. Before you answer, I just want to poke you regarding what C.K. Prahlad, the big management consultant, talks about the pyramid and the base of the pyramid. I suspect that may be what you are referring to when you talked about the scale economics, also in terms of the number of consumers. So yes, maybe a big company, either a transnational or a local national company, cannot sell their e-cigarette for $20 or $50, but they're going to sell it to a good 200 million people. Would that not be a good idea?
You see, there are, in the history of business strategy, there are a number of examples where when companies specifically see the potential of a certain product, they start pricing the products in terms of the quantities that they would eventually end up selling, right? So they calculate the price economics and the cost economics and the scale economics around what the volume is likely to be as opposed to what the volume is right now. And the cost starts falling in place very quickly. So there are a number of examples around it. And I think that is what is needed, right? And also, different countries have different scale economics, and one has to recognize that. I mean, that has been discussed quite deeply in this panel, right? So, the cost economics in the US is not the same as the UK, it's not the same as Indonesia, it's not the same as India. And that is something to be cognizant about, right? And, going back to the consumer-backed thinking, that how are the consumers going to buy if the product is going to be 10 times as what Joseph was mentioning in Kenya, right? So that just defeats the purpose. But I want to come back to Jose's point on disruption. Can companies disrupt themselves? Very, very difficult, right? Kodak had the digital camera in the laboratories for many, many years, and it was not Kodak. And it was, when Kodak had the digital camera, they knew that this was going to be a big success. They were actually investing in a silver nitride film plant, one of the world's biggest. So it's a very, very difficult proposition for businesses to disrupt themselves. And but the tobacco industry is doing very, very well up until now. So hopefully there is a different business model coming here. And I think there's one more point I want to say is that if the issue is big, right, the opportunity is also very big, right? And this is not an easy solution. And we've got a number of things that is impacting us around, in humanity right now. There's energy transition, there's climate, there's food security, there's water security, there's pandemic. And each of these things takes huge effort, right? The pandemic probably, I don't remember the number off the top of my head, but it was a few $1 trillion, right, to sort out the pandemic. So when there is a will, there is a way for people to come along, there's organizations to come along, there's pharmaceuticals, healthcare professionals, industry, regulation, and ordinary citizens on the road, right? They all came together and we solved the crisis. And it's I think probably we need to do the same thing with energy transition, and probably this also falls into the same class. I mean, we can't have so many unnecessary deaths.
That's a great way to kind of summarize what you came to the panel to talk about, and I really appreciate that input. You get the last word nearly, after which I'm going to summarize. But Flora, I love the fact that you had this ambition to go to 50 million consumers of BAT's reduced risk products by 2030. And that's a very commendable number, right? I mean, every person counts. Every smoker who has managed to switch to a safer product, I'm happy for that person. But in the global context, 1.3 billion people consuming risky forms of tobacco or high-risk products. 50 million, 2030, is the ambition too short? And can I sort of just provoke you to say, look, why not say that, look, we're going to conquer at least 500 or all the 1.3 billion and not leave anything for any other company, even?
Talk is cheap. I can say we will do 1 billion if you want me to say so, but there's a reason why that is a calculated commitment. But obviously, it could be more. And if we did 50 and the rest of the industry and the sector did 25, you are almost there. But with respect to disruption and Kozi's comment, I think the business model that you see in the new tobacco company, remember we are expanding to non-nicotine stuff, new source of income stream, optimizing our FMC cigarette business to get value in order to accelerate the other side. It's a matter of time. It's a matter of time. I don't think you'll expect that you can shut the door of the cigarette factory today and just because you have 20 million users on this side. That is why it's a transition. It's a journey. If you look at the oil company, that's what they're doing. It's no different. But more importantly, though, I pick up on the stuff that you said, Mr. Snooze. Yes. So you say, how can we... The Swedish model or the Swedish experience is something that you brought out that I think we have a perfect opportunity in November during COP to showcase that to the LMC countries and to ask them to look at and explore how that could be replicated. I think it's a perfect point that you bring, and I do hope that we utilize that opportunity on a global platform to talk more about how we offer the opportunity for every smoker, if they wish to transfer to something safer for them to use.
That's a great way to summarize what you came to represent here and also take it to the much higher level of global regulatory policy and correctly pointing to COP10 as the next kind of big milestone where some of the harm reduction voices have to have their voice and be represented accurately and not from a single-sided kind of viewpoint. Thank you so much for that, Flora. And thanks, of course, to Joseph and Atul for being such a bringing such variety of inputs, but also depth of knowledge. If I may summarize and finish this in the next 1 minute, I would like to thank you all for coming here, for sure. And also just flag what drove us to do this panel. It's important to remember that, as I said, 80% of the world's users of risky products live in LMICs, and that's not just a glib statement for impact. It has to be a reminder every time we talk about tobacco harm reduction in anything we do, saying, is our work going to reach the last person who's disadvantaged by this consumption, who's going to have 10, 15, 20 years less of his or her life, and their families are going to suffer with that. This is something that keeps me going and has done so for the last nearly 20 years in my career in this space. But every time you see anything that's been talked about at GFN and beyond, I would like you to have LMIC, but not just LMIC and disadvantaged populations in the developed world. Anyone who otherwise would not be a natural, logical person to pick up the next newfangled device that you think is cool. It may be fine for some of the current consumers who are using these products, but I think we have to take it way beyond where it is currently being used. And unless we have that mindset, all this is just a good, fun exercise, but it's not going to make any difference in public health. So if we want to own public health, we have to think of LMICs and disadvantaged populations. So I don't mean to preach beyond this point, but thank you so much for being very patient listeners and great contributors. So thank you so much to all. Cheers, please.
Thank you.